So this you've seen, but now I show you how they work clinically, and I will be fairly quick because I'm sure that Michael Keating will show you a little bit, and I'm finishing with what I think is most important for you. How are we using those drugs in the future? So don't worry, if I'm a little fast, I will summarize it in the end to show you when are we thinking to give which drug at to which patient. So this you've seen, and the beauty to correct these pathways, the imbalance of life and death signals with novel drugs. And go ahead, please. Yeah. So there's, I would say, two types of these novel agents, the BCL2 antagonists, ABT199, that is even not approved, but I think it will be approved next year, at least in the US and maybe in Europe. They're working hard on this. And basically that drug can achieve complete remissions by itself. So it's very potent, probably the most potent single agent that we have available for CLL so far, ABT199. And it's highly active in deletion 17p patients. And then the tyrosine kinase or kinase inhibitors, and there's 2 drugs approved. There's more in development, but I'm just talking about those 2. And what you can see here in refractory patients as single agent, they have good responses, so the overall response rate in all of them is around 70 to 80%. But these kinase inhibitors very rarely induce complete remissions, so they are less potent as a single agent. You have to continue treatment over a longer time. That's the difference between those groups of agents, so the kinase inhibitors. So Ibrutinib, led by this landmark trial by John Bird, targeting Ibrutinib in relapse. No, this one here, what you have to know is when you get this drug, the response comes slowly and you have to be patient. Which is what you are anyway, but even more patient, you know. Even more patient because sometimes it really takes months until you see the blood counts improving. That's why I'm showing this. And you have this transient lymphocytosis in the beginning, which is another problem, but usually the patients feel well and the side effects are minimal. Next one. And the important thing why these drugs are of so much help is that they seem to work in deletion 17p. If you look at the outcome of this study here, the progression-free survival is better than with any other drug, than the survival of any other drug that we had so far. So it's a clear improvement in this poor risk population. And you can now understand why, because it's shifting this balance. You know, this is the mechanism of action, actually. It shifts the balance of life and death signals, so cells are getting more prone to apoptosis, despite the deficiency of the apoptotic pathway. Next one. They don't need p53 to act. So chemotherapy needs an intact p53, needs the thing on chromosome 17 to actually exert its action. Ibrutinib does not, because it's shifting this balance. All right. However, you have a dysfunction sometimes, so you can acquire mutations, and one of the problems with these agents is over time you really have to watch the patients carefully. Some of them do very well over years, but some don't, and especially the ones with an imbalance of this, with p53 mutations, with ATM mutations, they can develop resistance, and that has been shown in this paper. So the binding cleft is changed, then Ibrutinib can no longer form these bindings very efficiently, and that can cause resistance to this drug. So the pathway is basically hampered in these patients, and that is one mechanism that physicians have to watch out with you when they treat with Ibrutinib. In combination with an antibody, it's even more potent, and that is a randomized trial, and I will show that quickly. Next one. Here, the best response to therapy is clearly improved when you combine an anti-CD20 antibody. I think it doesn't really matter which one, but it's better to use this combination than the drug alone, and this trial was the first one to show this. And shows impressive differences in overall survival and progression-free survival. Again, and that's actually the thing for us, for physicians and you to think about, the good choices matter and have an impact on your chances to survive. And maybe that's also why you're here. You really, with your physicians, need to make the good choices and no longer do whatever you like because it can actually change the outcome. And I think that's explaining also why the Manitoba patients in centers seen by experts may do better now, because they are, this interaction with a specialist is now something that is beneficial for the patient. Idelalisib, the PI3 kinase inhibitor, a very potent agent as well. Here's a randomized trial that used already a combination testing against an antibody. And next one, this was the trial design. So idelalisib with rituximab against rituximab plus placebo. And again, huge differences in progression-free survival and overall survival. So these agents, the kinase inhibitors, are beneficial when tested in these trials. And finally, this novel BCL2 inhibitor, the one that is attacking the cell death pathway, that's, as I said, the most potent one, so potent that we had to reduce the dose and really start with very low doses, 50 milligram, because it was too potent and was inducing tumor lysis in these patients. But if you do this, you see this is responses. We call this waterfall plots. Here, it's a good thing actually to see at the Niagara Falls that this is a really steep decline here, basically fitting well to the site where we are speaking, that most patients respond. So from 0 response to 100, and most of them responded. And you have to be reminded, this is all pre-treated patients, all heavily pre-treated, some of them with deletion 17p, and all of them ABT-109 works. Again, one problem, in my experience, we have now treated a lot of patients in Cologne with this agent. They can relapse rather quickly, and then the options are minimal, and these patients you have to really follow to avoid that they get Richter's transformation and stuff, which is difficult to treat. So that's a new challenge for all of us, for the clinicians, and Mike Keating will certainly talk about his experience on those things. I think that's a novel thing. Some of them do extremely well, and especially if they are overcoming the initial phase, have no side effects. Translation into clinical practice. So now, I would say if you have not understood anything, or it was a bit too fast in the last part, I will show you a few slides where you can see how we actually recommend treatment for which patient group in our study group and in Germany. First line treatment 2015. So basically we still look at the stage. Maybe in a few months we don't, but right now we still do. Then we look at the fitness with this go-go, slow-go categories. In the initial stage, we don't treat, so fitness is irrelevant. We watch and wait, and a third of our patients, if not more, are in this group. When we have active disease, and that was as exactly defined this morning by Dr. Fraser, active disease is symptomatic or advanced stage, and the symptoms were shown by him. Then we look at the chromosomal deletions, especially deletion 17p, and also at p53 mutations because they are identical in function. Sometimes it's only mutated, and we think it's about the same number of patients that have a p53 mutation as compared to deletion 17p, about 7% each. So if they have one, that's a different group, and that's in green. So no such unfavorable mutation means FCR for the fit patient remains the first choice. Above 65, BR. If you have a deletion 17p or a p53 mutation, we don't use any chemoimmunotherapy anymore. We go immediately to Ibrutinib or idelalisib plus rituximab. And the question is whether or not we need an allogeneic transplant afterwards. Right now we don't do it. We only do it in the second relapse, but that's an open question. But we have done a lot less allogeneic transplantations over the past few years than we used to do before, maybe 2 or 3 last year as compared to 30 in our center per year. So that has totally changed. Allogeneic transplantation has become less relevant. For the slow-go patients, just one back. For this one, we need a bit more time. Slow-go patients, so the unfit patients. First line, if you don't have a deletion 17p, is Temrembicil obinutuzumab for us, if available. So the most potent treatment that we have currently available, but it's justified to use rituximab or eventually ofatumumab, so an anti-CD20 antibody, not alone. So combination is key. If you have a deletion 17p or p53 mutation, again, the first choice is Ibrutinib or idelalisib plus rituximab, and they have been approved for that. Next one, what to do about relapse? Here, the question is, how long did the last success last? If you relapse immediately or within 2 years, you can repeat what has been done before. So a patient that has received bendamustine, rituximab, or FCR 10 years ago, and everything has been unchanged, and now it comes back. Why not repeating this? It's one very good possibility. If, however, the disease comes back quickly, it's a high-risk situation, then we switch, and in the relapse setting, we switch to Ibrutinib, eventually idelalisib, and then the question, the fit patients, is whether or not we go for a transplant or not. That's an open question. In these logo patients, we have many options, not a real standard, and what you can try is listed on the alternative. So Ibrutinib, idelalisib, ABT-199 if available, lenalidomide, R-square, which means lenalidomide plus rituximab, so many options, and you can try them sequentially. There's nothing that is clearly better. I would probably start with a kinase inhibitor. So that's how we are directing choices in our patients in Germany or in my center, and you see that it becomes a lot more personalized and a lot more refined how to make these decisions. Now the future is this, because what we want is to use all these agents in a short time to save money, to avoid that you have to be treated forever, and to basically combine the best agents to achieve a control over this disease. And this is currently done in a series of trials that we call sequential TTT, so tailored, targeted, and total eradication, and where we use a debulking step sometimes, then combinations of kinase inhibitors plus antibody to induce, which is, for instance, ABT-199 plus G101, or what we've done. So it's a tailored part in it. So we treat to debulk if there is too much tumor with maybe 1 or 2 courses of bendamustine. Then we use a combination in trials. That's only in trials. But I think that's a beautiful trial design. At least we are convinced because we have seen it in patients. It really works well. And then finally, to tailor the rest of the maintenance therapy for those patients who still have disease after this initial phase, and to get rid of it, if possible, by an additional maintenance phase. So a clever sequential combination therapy is how I think we are going to use these novel agents, and there will be almost no chemotherapy in that anymore in the future. To conclude, and this is, well, basically the trials that we are currently doing in first line in Germany. And as you see, I will be extremely quick on that. We go from chemotherapy now to combinations, and one of the combinations for the fit patients, if you look at the future CLL13 in green, is the triple combination of Ibrutinib, ABT-199 plus G101. So using the best agents in one thing immediately to really get rid of the disease and have as many patients as possible MRD negative to get long-lasting remissions, because we know from our previous trials that if we achieve this, the prognosis usually is a lot better. MRD negativity is a good thing in clinical trials to have. So that's why we are aiming for this. And in these logo patients, again, we use ABT-199 plus G101. So what you see here is our attempt to really get more efficient now with these agents and not use any chemotherapy anymore if possible. That's the future. And